Here's a case of a young woman with Crohn's disease, currently on anti-TNF therapy. So I'm going to tell you a little bit more about her in the next step. So she's young, she's 25 years old. She is an early childhood education student currently. She's been dealing with Crohn's disease for about 8 years. She has previously been on 6 mercaptopurine in the first 2 years of her disease, and then she was switched to azathioprine for many years. But currently, she's very well controlled. She's been tolerating her infliximab infusion. She's been adherent to her treatment since about 2010. Her past medical history, I'll just give you some pertinent past medical history. She did have her tonsils removed when she was 10 years old. She's been dealing with on again, off again trouble sleeping. Most recently, her roommate had tried Valerian Root and said it worked, so she's just starting Valerian Root for insomnia. Her laboratory tests are really unremarkable. She has a normal CBC, CMP. She's been tested for TB and hepatitis, and she's negative. Some of her social habits, this woman rarely drinks, just on occasion, maybe 2 or 3 times a year, she says, when she's at a wedding. She quit smoking about 5 years ago, but did start smoking at an early age. So she comes in with 3 months history of a new rash on her scalp, which I'll show you, and then I'll pause a little bit for some questions. So this is her scalp, kind of, along with some hair loss, some thick, scaly rash. She hasn't never had a rash really before, no scalp disease, no real problems with her skin, and another picture of her rash.
Elaine, could you show us the previous picture so we could look at her fingers a little bit more carefully?
Sure.
Okay.
Get a good view there? Mm-hmm. Diagnosis.
So summarize this. Give us an illness script here to summarize this.
Sure. So young woman with really well-controlled Crohn's, otherwise no other past medical history other than having some trouble sleeping, and presents with sort of first-time ever rash, no family history or history of rash in herself. I'm just going to move on a little bit. She also more recently developed some angular chelosis around her mouth, as well as some rash further down in her legs. So just off the top of your head, some immediate thoughts. No diagnosis, just kind of what's the differential at this point. Don't have to tell me what you want to do, just shout out some ideas that this could be.
So we're sitting there in a combined rheumatology, dermatology, gastroenterology clinic at the Cleveland Clinic. 3 different subspecialists standing around this woman, and the poor rheumatologist and gastroenterologist turn to Abrar and say, "Abrar, what the heck is this?"
And I'm sure most
rheumatologists... we can't really get into a dermatology office right away in real life.
Wait,
I'll see
wait
a
a second,
patient next year, 2015, and meanwhile the patient's like, what do I do with my rash?
Is that how long it takes to get in to see you?
Well, we're actually much more responsive to that nowadays, I think. But that's a great question, Philip. And looking at this particular image, I think all of us, sitting up here would probably agree that this looks very much like psoriasis. You certainly see the red plaques. They're on an extensor extremity, or 2 extensor extremities. You see the silvery sort of whitish scale, and part of the scale is missing on a couple of plaques, revealing some areas that might be eroded or bleeding point, which seems quite classic for psoriasis. But as I was taking notes, as Elaine was describing the case, she's never really had a diagnosis of psoriasis, but has had Crohn's for about 8 years. So it just begins to make me think, we're certainly seeing more and more of these cases in clinic now, who've had either diagnosis of an inflammatory arthritis, either seronegative for many years, and or Crohn's, who've been on anti-TNF therapy for a number of years, typically 2 years or more. She's been, I think, on at least infliximab for a while, who develop a psoriasis-like eruption or psoriasis itself. So that's certainly possible. But if you go back to the previous pictures, like that picture, that's interesting because when they get this kind of an appearance, sometimes we like to look inside the mouth because these patients with Crohn's can have mucosal Crohn's as well. And I'd certainly be interested in asking her if she has any vaginal erosions or vaginal lesions, because we are seeing a number of patients with mucocutaneous Crohn's that can sort of present just like this. And it looks like angular cheilitis on the outside, but it wraps right around the lip inside.
And Abrar, can you remind us about things like pemphigus or et cetera? What would they look like?
Sure, that's a great question, Philip. Typically pemphigus of the mouth will look much more eroded. It doesn't present with the angular cheilitis, but you can see erosions of the actual lips themselves. You can see hemorrhage on the lips. And if you look at the tongue or the buccal mucosa, you'll see frank erosions. They can be up to a centimeter in size, and the mucosa basically is very, very friable. Typically in Crohn's or mucosal Crohn's, you'll see ulcerations along the gutters, so the inferior gutter where the gingiva meets the buccal mucosa, or in the superior gutter on the upper jaw. And certainly in the perianal, inguinal areas, you'll see knife-like ulcers in the inguinal crease, or right on the vaginal mucosa itself.
And how much do you, for the anti-TNF induced psoriasis, typically that's supposed to be, well, 2/3 of the cases are palmopustular, and this is not looking like palmopustular disease to me, but I want to hear your comment about it because it's a very severe change in the scalp.
Philip, actually, that's a really astute observation. Let's go back to the scalp lesions. If you go to this picture and even the image before this, that's a great point, Philip. When we see, there's almost hair loss in that patch,
right.
And again, I can't tell, but the next image is much more profound. And when we see this, we worry about almost sort of a boggy change clinically. We'll be examining them, looking for pustular changes as well. And that, again, we think more about a TNF exacerbated response.
Yeah.
But I'll say that sometimes in these patients, we're thinking also of a psoriasis like diathesis. So they may have Crohn's, may have a diathesis for psoriasis. I'd be trying to reach one of my room colleagues, to ask about, having this patient examined for inflammatory arthritis, maybe even sort of an axial variant. And we almost always ask all our patients about eye symptoms as well in these situations.
And what would you be anticipating might be seen on a biopsy, and would you do a biopsy in this situation?
Yeah, again, that's a great question, because if it looks pustular, sometimes we will do a biopsy, because we're worried also about infection. She's been on infliximab for a while. We have seen occasional infections sort of masquerading like this. Not as systemic, so not with scalp and mouth and lower extremity involvement, but it does cross our minds, especially if you see changes like this.
Mm-hmm.
So let's go back to the eye symptoms. If she says she doesn't have any eye symptoms, am I done? What? Does she need to go on to more testing? Be seen by an ophthalmologist?
Doug?
So the answer is probably not, because most of the uveitis that they're going to have with Crohn's is going to be a symptomatic uveitis. And it's not like JIA where you have an asymptomatic uveitis. We're always happy to see anyone, but the odds are you won't find anything.
Okay.
Elaine, this is JP Achkar. Can you hear me?
Okay, let's introduce JP.
This is Dr. Jean-Paul Achkar. He's a Cleveland Clinic gastroenterologist who focuses on inflammatory bowel disease. So yes, welcome.
So yeah, just chiming in on the conversation. Can you hear me okay?
Yes,
great.
we sure can.
Chiming in on the conversation, certainly the points about oral ulceration and things like that should be considered, but my thinking is you're saying that her Crohn's is otherwise uncontrolled, so I'd be less focused on that. The other thing that I'm thinking of with the angular cheilitis, some kind of vitamin deficiency there. And, with their underlying Crohn's, certainly iron and B12 would be that we think about. But if I want to tie into the rash, those don't necessarily make sense. If I wanted to put it all together, I don't know whether the rash makes sense or not, but zinc deficiency would be something else I'd be thinking of, lady. But and then the alternative that people have already brought up of anti-related rash in the angular that.
Could I ask, one of the, and those are all really good points. I think the angular chelosis seems a little disjointed from the rest of the skin diathesis. But in this psoriaform looking rash, is there, in the setting of a TNF inhibitor, aside from manipulating the drug, is there anything on biopsy that can demonstrate positive predictive or negative predictive that is a drug-associated effect?
Lenny, good question again. There's nothing on biopsy specifically, but if we, going back to Philip's point, if we see more of a neutrophilic change, so pustulation, we're leaning more towards typically a TNF-provoked change. But other than manipulating therapy or actually managing patients, it's really hard to predict. Often, though, GI will play a very important role, of course, in the management, because if the patient's Crohn's is under control, or if we're working with a rheumatologist and a patient with inflammatory arthritis, if the arthritis is under control, then we'll lean more toward more on our sort of colleagues to decide which way to lean.
Could I do a informal poll here? How many out here have encountered a psoriaform complication from a TNF inhibitor in your practice? Looks like at least half or so.
Can I ask, would you actually stain for TNF in your biopsy?
Not routinely done.
Do you think that might, because in our we saw, when we first started using TNF inhibitors a long time ago, we saw a lot of this, and there is the palmapustular version that Philip's talking about, but there was you were getting the ones which seemed to be an on-off phenomenon, especially with as secondary non-response was occurring, and that sometimes the skin is the more sensitive, and we used the presence of TNF as a justification for switching to another TNF inhibitor, usually with very good responses.
So before we go more onto therapy, where would you biopsy, Abrar?
I'd be really curious about the scalp because the hair loss does bother me, and I wonder if there's something else going on.
So you would choose the scalp?
Probably, yeah.
Can I ask about two other these are just sort of out of left field. Can you comment on lichenoid or lichen planus, and can you also comment on bullous pemphigoid?
Sure.
Please.
So there, what Philip's alluding to is there are a number of other manifestations that you can see in skin on patients on TNF therapy. They can occur in various sort of morphologies. The commonest we see is psoriasiform, the kind you're seeing. So red plaques covered with thick scale, typically silvery or whitish. We also see a lichen planus-like eruption that can occur in the mouth and on the skin, typically very itchy. They're very violaceous of purple in color. They're not erosive, they don't erode, and there's almost no silvery scale, but basically sort of a thick adherent scale. And then we have seen some cases of course, both bullous disease as well as cutaneous lupus. This doesn't fit either of them, right this second. Bullous pemphigoid is very obvious. You'll see actually bullae on the skin. But in terms of cutaneous lupus, much more photo-distributed on the extremities and face, and we have seen that as well. But again, this doesn't fit that classic, collagen vascular disease like change that we see with TNF therapy.
So one comment about going back to the TNF-induced forms of psoriasis. In one of the large case reviews, 330 cases or so, about 70% of the cases were more of this palmapustular variety, but 30% were just standard plaque psoriasis, although this looks pretty aggressive. And as Paul alluded to, you don't have to necessarily abandon the idea of using anti-TNF therapy again. You can either switch or even sometimes treat the disease and come back to the same. But so it's there can be a variety, as Abrar is saying, psoriaform manifestations.
So summary to this point, it sounds like top on the differential is this TNF, psoriasis induced by TNF therapy. We also heard the differential of other cutaneous manifestations that this could be. Lower on the list, I heard a little bit about maybe some worry. She's immunosuppressed for many years, maybe have to do some special stains, biopsy, maybe infection, immunocompromised host. But really, when she came in my office, she just expected me to give her some cream. She's actually not so bothered by the rash. She's really bothered that she can't sleep. and she's tired, and she can't go to school. And so, Dr. Roizen, can you comment on Valerian Root and whether or not we should be doing something more for her sleep?
Valerian is a GABA, if you will, agonist, and has the same properties as diazepam or Valium or any of the other benzodiazepine drugs, and can make you tired, can give you a hangover, and can cause long-term problems. So I don't think of it as anything special, if you will, from a choice of anxiety or sleep.
Okay, thank you. Just the spectrum of just having autoimmune disease, or anybody on the panel have experience with patients with Crohn's and psoriasis?
Yeah, frequently.
Sure.
Right.
Sure. But I think we're all worried that this is just a weird-looking psoriasis, if it is. So that's why I want Abrar's help with the biopsy.
Yeah. Does she scratch her head in her sleep under the influence of this root?
Oh, this root. There you go.
So, I mean, I think that the elephant in the room, that this is a drug-induced phenomena that you can't clearly rule in or rule out. So you're either going to de-challenge or push ahead and treat this. So, I mean, that looks like a pretty bad rash to me.
Yeah, so at this point, Abrar's vacationing in Cancun. He can't get that biopsy. So do I stop the infliximab while I'm waiting, or do I switch a TNF? Thoughts around what to do at the moment, point of care?
Well, I think you have to lean back on your GI colleagues. I'd be curious to know what Dr. Achkar thinks. If the Crohn's is indeed quiet, it's going to be very hard to convince your GI colleague to switch.
It is quiet.
And in that case, we'll do everything we can. Going back to Lenny's point, I think I would probably, the skin needs more drug, often. And if it's not very pustular, will persist. Exactly what Philip and Paul mentioned. Persist with the TNF agent. We might add something to it. So we definitely add topical therapy, topical steroids. We will definitely either increase the frequency of the infliximab in this case. So I think you had said, I forgot the dose, but maybe 5?
She was on 5 mg.
5 mg, okay. So, we might keep the same dose and increase the frequency. Most of the time we see our RA and Crohn's patients on a Q8 week regimen. Skin we typically treat on a Q6 or Q4 week regimen, actually. So I might increase the frequency and see how she does. But again, going back to Lenny's point, it takes a while to see them respond. I mean, it takes about 3 cycles of infliximab, so about 2 to 3 months. So if the patient doesn't want to wait that long, we might add methotrexate to the regimen. If we don't see a response, then we can, or clear worsening after infusions, then we might debate switching.
So you think that this patient actually needs more infliximab?
Yeah, because her Crohn's is quiet and her skin isn't bothering her too much, which I'm surprised at because her scalp is quite severe.
She can't see her scalp. You see, we can see her scalp.
That's true too.
She's not really bothered. So she's thinking she just needs topicals. But at this point, I'm really curious to really hash out what we're going to do with the infliximab. So are we giving more, or are we taking it away?
Let's just say, for sake of argument, that she is bothered by this. All right, so, that sounds a little atypical. I'd like to know what the masters think about the strategies of switching, and do you switch molecular structures? Do you stay the course? I see Philip nodding his head here.
So I must admit, although I still want to have
A biopsy.
Abrar's colleague give an opinion on the biopsy and tell me that I'm not going down the wrong path, but I would probably stop the infliximab. And if her Crohn's is medium active or active, I would then switch to a different agent, such as either certolizumab or adalimumab for treatment of it.
What is the evidence, Phil, that that's out there that if you switch to another anti-TNF, you won't make this worse or improve the situation? Is there any evidence that one way or another?
Only case reports that show that this can work, and then my own personal experience with it.
Do you think that infliximab, which is the most powerful, presumably the most potent of all the anti-TNF drugs, you're killing off all the TNF you can possibly imagine in these patients from the very beginning of time, there must be some reason why this is seen a little bit more frequently with infliximab than with the other anti-TNF agents.
So there is some speculation at a molecular level, and although I'm with some esteemed immunologists, I'll throw out there what has been at least speculated, and that is that you're shunting myeloid maturation from a predominant ratio of myeloid dendritic cells to plasmacytoid dendritic cells, and that infliximab may do this a little bit more than some of the other agents, and you get more alpha interferon production, and this may contribute to either the autoimmune lupus or the skin manifestations of psoriasis. At least that's a speculation. So I think that there is some rationale to moving away from infliximab here to another anti-TNF if there is a rule out of other reasons, either infectious or another dermatologic diagnosis that we're missing altogether that the dermatologist has helped us with.
And actually, I would agree with Philip. I think the time when we consider switching even more is if we see pustular changes, because in those situations, typically continuing on the same TNF doesn't work as well. But again, you can be heavily influenced by GI, especially if the other disease is doing well. Then
JP, you have any comments on what?
Yeah, the only other option, if we're talking about case reports in situations like this, there have been a couple reports of switching from an anti-TNF to ustekinumab, which, as we're aware, works for the psoriasis, but there's also some early evidence that it works for Crohn's disease, so some people have done that. And, as of a few months ago, there is a different class of biologic therapy, vedolizumab, that is now FDA approved for treatment of Crohn's disease. So from a Crohn's standpoint, I might not necessarily feel compelled to stay in the anti-TNF family if I was concerned that this was a anti-TNF mediated type reaction.
So, and just one more comment, we've certainly used both those agents with our GI colleagues. Dr. Achkar, have you used Tysabri or natalizumab in these cases? Because we've had success with a couple of cases who had the same reaction, and they were switched to Tysabri and did quite well both for Crohn's as well as their psoriasis.
Yeah, I've not used natalizumab for this particular situation, but with in May of 2014, vedolizumab was approved, the cousin of natalizumab, and pretty much none of us are going to be using natalizumab at this point because of the concern with PML, with the natalizumab that does not appear to be there with the vedolizumab. But I think we're barking up the same tree here with using a different class of biologic as a potential option rather than sticking with the anti-TNF family.
Oh, here's some other pictures, some fissuring associated with some TNF-induced psoriasis to show you. So basically some take-home points, as we talked about, class effect versus changing MOA, agent-specific effect, unmasking or provoking that diathesis we talked about, and whether we're treating through the reaction or we're changing therapy. Thank you.
Great.